Hey guys, welcome back. The topic we're going to study now is pneumonia. And the first and the foremost thing that I would like to highlight is that if they begin a question by describing an AIDS positive patient, they mention a patient having low CD4 count, like normal is in the range of about 800 to 1200 cells per cubic millimeter. Here it is outrageously low, 200 cells per cubic millimeter. But he mentions that the patient is having productive cough, respiratory distress, auscultatory finding of bronchial breathing. Then the first answer that you will give for this particular case would be pneumococcus. I agree to the fact that obviously Pneumocystis jirovecii would also be present in the choices and would have come in your mind. But the point is, if I say bronchial breathing, then one of the important auscultatory findings of lobar pneumonia is bronchial breathing. I will describe the characteristics of bronchial breathing as we progress in the discussion, but at the moment I want to highlight that when it comes to Pneumocystis jirovecii per se, most of the time there are paucity of auscultatory findings, or you could be getting maximum some crackles, and even those crackles that would be present would be scattered and they would be unaltered by coughing. Why I said unaltered by coughing? Because per se the pus in Pneumocystis jirovecii is not in the alveoli, it is in the interstitial space. So you always read this statement: if the crepitations are altered by coughing, that's when there is a alveolar component, there is pus in the alveoli, because pneumonia is after all a disease where there is exudate present in the alveoli. But in Pneumocystis jirovecii, it's an interstitial pneumonia, so the crepitations are unaltered by coughing. I would like to highlight this fact that this question came in even NEET 2021 and there was a huge controversy related to this. I would like to not call it a controversy because that's a standard fact that is given in Harrison, and anyway bronchial breathing has to be given the due respect that it deserves, which is that this is a feature that you see with lobar pneumonia. I have therefore also kept a couple of images here. In fact, there's a possibility that they might deliberately give you a pediatric setup. The child would be having fever, cough, breathlessness, and would be very restless, not taking feed. Danger signs in the child could be described, and radiologically speaking, there could be one circumscribed round shadow in the chest X-ray. Now, when you read a round circumscribed white shadow in the chest X-ray with features which are suggestive of a lower respiratory tract infection, then your first thought process would be that this could be round pneumonia. Yes guys, pneumococcal pneumonia may not cause the traditional lobar pneumonia, which is also shown in this chest X-ray, but it might actually contribute to development of the circumscribed shadow, which might actually look like a lung mass also. In fact, if I was describing a circumscribed shadow in a chest X-ray in any of the lobes of the lung, especially in an adult, you would have thought in terms of a lung cancer. But if it's a short history, there's fever, there is purulent bronchuria, there is productive cough, there are crackles, there are bronchial breathing present in a patient, then round pneumonia definitely deserves the importance that it would be occupying in MCQs. The number one organism for this also happens to be pneumococcus. And in the same image, I've also shown the right middle zone consolidation. In fact, one more feature that you can see is that the heart is white and the lungs are also white. So I can say that normally you can see the cardiac border, in a sense that when the cardiac border will end, the heart will be white and the lungs will be black. But here you can see that the entire whiteness is spilling over. Heart is also white and the lung is also white. So I can therefore say an alternative term here, that is Selhout sign. Though you are aware of these aspects from radiology, but I thought that I'll just freshen up the basic facts. So lobar pneumonia / round pneumonia, the organism would be answered by you as pneumococcus. Even in an AIDS positive patient, bronchial breathing given, the answer is pneumococcus. Plus, if you remember the CNS discussion, I have told you that the number one cause of acute bacterial meningitis in both pediatric as well as adult age group happens to be Streptococcus pneumoniae / pneumococcus per se. So because this organism comes up multiple times, I thought that I'll just use this opportunity to mention how many times pneumococcus has come in our discussion. 3 times I've written and 2 times I've said it verbally. I'll repeat the verbal statement again. The leading cause of acute bacterial meningitis in pediatric age group and adult age group happens to be pneumococcus. Now I would like you to compare this with the X-ray which is given inferly. This patient was on a ventilator and then subsequently bilateral infiltrates are developing. So you are noticing that this X-ray will look like either that of a patient of ARDS or the pattern which is present here of diffuse bilateral infiltrates, I can call it like a bronchopneumonia, and because I gave a history that this patient is already intubated and now is having high grade fever, so I obviously have to think in terms of ventilator associated pneumonia. You very well know the definition. Nosocomial pneumonia would be defined as pneumonia developing after 48 hours, but here I'm specifically emphasizing on ventilator associated pneumonia, which would give features of bilateral infiltrates. And if he says what's the organism responsible for ventilator associated pneumonia, then the first answer for you would be given as Pseudomonas. Now listen to my facts very carefully, because I agree to the fact that gram-negative organisms would primarily be the ones, and in some of the books and in some of the apps they have mentioned that in AIMS they have found that Acinetobacter happens to be the #1 cause for ventilator associated pneumonia. So I respect the finding that okay, they would have done a study, maybe multiple AIMS collaborated and they found out Acinetobacter, but in Harrison he has first mentioned Pseudomonas for multi-drug resistant organisms that contribute to development of ventilator associated pneumonia. Now, I said why pay attention to this is because they can definitely twist this MCQ, because they've already asked for MDR. They might say non-MDR. Now, the question arises, if it's going to be a non-MDR ventilator associated pneumonia, what would be the causative organism? Then the answer is pneumococcus, and the query of most students is, sir, where did it come from? You see, this guy was actually a case of initially, I mean, let me say this particular chap, he was put on a ventilator because he was having COVID-19 pneumonia, maybe, right? But the tubings that were used in the ventilator, they were not sterilized properly and they were from a different patient. I mean, most of the time hospital acquired is primarily because of the growth of the microorganisms, because the hygiene component in especially government hospitals can be compromised. So this could be infected tubings which could have resulted in this patient ending up with pneumococcal pneumonia. So I wanted to remember ventilator associated pneumonia. It begins as I would say respiratory bronchiolitis. The disease process will involve the smaller airways, that is bronchioles, and then would be present in multicentric areas of the lung, in contrast to lobar pneumonia, or let me say in contrast to round pneumonia, which I showed initially, which were having focal lesions. Now, once you get these facts right, I also want to use this opportunity to mention a patient who's having these diffuse bilateral infiltrates in the lower lobes. Though, I mean, in pneumonia, we really can't predict that, okay, what is the organism on the basis of lobar involvement, but you would have noticed that in the outbreak of SARS-CoV-2, that is COVID-19 pneumonia, in majority of cases, it was the lower lobe that was majorly involved, though obviously we have a CORAD staging and we have a CT severity score available, and I've discussed that in COVID per se, but I just wanted to highlight that in the current scenario, if you have somebody with fever, there's a difficulty in breathing also, the oxygen saturation is falling, and the chest x-ray shows, which is a very inexpensive tool, lower lobe infiltrates. I mean, not everybody would be in a position to afford a CT chest and you would be picking up ground glass opacity. So lower lobe involvement, you could think in terms of COVID-19 pneumonia, though I want to highlight obviously that COVID-19 pneumonia cannot be diagnosed on basis of a chest x-ray. I would definitely be requiring a RT-PCR or maybe a rapid antigen test for identification of this infection. So first and the foremost, in this particular slide, I have tried to highlight regarding the important organisms, and majority of questions in the exam would be having an organism specific approach. It's only the fact that lots of time integrated stuff is asked. So we will also look at development of pneumonia from a pathological perspective. And while I'm writing this, I also want to say that in pneumonia, the main danger is not that the bacteria are proliferating in the alveoli. We can handle that. It is the host response. It is our body's response which causes extreme amount of alveolar exudate, and this alveolar exudate actually compromises the gas exchange. So most of the time in pneumonia, you would have seen this in COVID-19 also, that it is the host response which could be so florid, so extensive that it can contribute to cytokine storm, and the person will rather be developing a MI or maybe developing a pulmonary embolism, he would be developing multi-organ failure. So it's not that only in COVID-19 we are saying that it's the host response that is causing problems. Even in routine cases of pneumonia caused by bacteria, it is the host response which contributes to a lot of trouble. So initially, what happens when these organisms would be going into the areas of the lung which are supposed to be sterile, there will be a development of alveolar edema. Now, at this point of time, X-ray most of the time will be normal. So a patient who's having a lower respiratory tract infection or pneumonia, if he comes early, you would not be getting the standard consolidation or the infiltration that we see. At this point of time, all that is happening is that the security system is gearing up. There is exudate in the alveoli of the patient, and he's, especially geriatric age patients, might present only with confusion and disorientation. But then subsequently you would be reading about the stage of red hepatization and gray hepatization. So along with organisms, it's a possibility that in one of the choices he might incorporate this information also. In red hepatization, obviously the red blood cells are also crossing over from the blood vessels into the alveoli. So you would be having red blood cells and neutrophils, the security system, the SWAT team, which is sent when the bad guys are coming, the terrorists are coming. So the neutrophils are at the moment present in large amounts. Then subsequently you have a stage of gray hepatization. What does gray hepatization signify? It signifies containment of infection. Because now what's going to happen is that the bacteria, the bad guys are getting or starting to get destroyed. So why you call it a gray zone is because the red blood cells would start getting lysed. At the same time, there will be fibrin deposit in the alveoli. There would be a possible fact that even the oxygen saturation may not picked up at this point of time, but the patient will not be feeling, I would say, perfectly normal. You may not be very comfortable discharging the patient. It takes a while for the antibiotics to act and to ensure that you get a good resolution, because lots of time, as I said, it's the alveolar exudate which contributes to a delayed recovery. So there's fibrin in the alveoli. The security system is very much present, and then it takes a variable time depending on the amount of damage which is caused. First, the bacterial or the viral load that was inhaled into the lungs, the amount of damage present, and then the host response. Both of these decide how much time it will take for resolution. We can't predict. A single, I would say, shoe would not fit everything. So we cannot predict that, okay, in how many days a patient of COVID-19 pneumonia would recover. You would have seen variation, obviously. That's the same case with even pneumococcus as well. So there's no standardization that, okay, we give antibiotics in pneumococcal pneumonia for, let me say, 10 days, but then there is a distinct possibility that some patients might take a little longer to recover. When it comes to the resolution phase, then it's the alveolar macrophages that would come in. So you can remember like this, that the alveolar macrophages are like the routine police. You see, normally whenever there is a law and order problem, they will call in the special riot police, or they will call up the national security guard. So you can consider neutrophils as that special team that comes in to handle in the bad guys. Otherwise, routine police would be alveolar macrophages, and subsequently the resolution of infection would be coming. And most of the time they would love to ask you regarding the stage of gray hepatization, where RBC lysis occurs, the neutrophils are still present, there would be some fibrin present, but the good news is containment of infection has occurred at this point of time, and subsequently recovery will occur. On the basis of this information, I hope it's now clear, but the fact that if he just begins the question by saying what is the number one cause for community acquired pneumonia, then your answer would be given as pneumococcus. But I saw a very interesting trend in questions, and that's mainly based on the fact that since pneumococcal vaccine is available now, especially in geriatric age group, because even in India people have now become more careful with respect to vaccination, because once COVID vaccination has picked up, now private doctors are recommending especially old age people after 65 to even going for pneumococcal vaccination. So the incidence of pneumococcal pneumonia is reducing, especially in America. And since we are following American book Harrison, so he mentions the fact that Mycoplasma pneumoniae is gradually emerging as an important cause of community acquired pneumonia. And why that is important is because this would not be responding to beta-lactam. You will have to give macrolides for management of this patient. If Mycoplasma pneumonia also is not in the option, then you also need to consider Haemophilus influenzae. Though all these data has been determined on the basis of doing a sputum culture, a PCR on the sputum or on the bronchial lavage of the patient, the first answer is pneumococcus, then Mycoplasma pneumonia, then Haemophilus influenzae. Now, if he just tries to be smart and says that a patient is admitted into intensive care unit with pneumonia, what is the common organism? Whenever we read the word intensive care unit, we assume it is ventilator-associated pneumonia, but there is a possibility that the patient with pneumococcal pneumonia was having a high curve score. I will be describing curve 65 score subsequently. I'll just verbally say it at the moment: confusion, urea elevated, blood pressure on the lower side less than 90/60, respiratory rate of the patient which is more than 30, and age of the patient more than 65. So if a patient is having a high curve score, like let me say a score of 3 or higher, I'll be describing these parameters in written form subsequently before you, but at the moment I'm just saying my patient was having a curve 65 score of more than 3. That is the reason why he was admitted into intensive care unit, but he is the patient who was actually a patient of community acquired pneumonia only. So even here the answer would be given as first, pneumococcus. You see, every patient of pneumococcal pneumonia will not be only receiving a home treatment. Some would be requiring admission, some would be requiring intensive care unit, some would be requiring intensive care unit with mechanical ventilation. So the point is, this patient is getting infection from the community, and that is why he was admitted into your intensive care unit. And those who are in routine, your general ward, even they would be having pneumococcal pneumonia. The AIDS fact I've already explained to you. Obviously, I mean, you need to have findings of lobar pneumonia. You need to have mucopurulent sputum present, because in pneumocystis jirovecii, you don't have a mucopurulent sputum, and most of the time there is paucity of lung findings. I would also suggest you to listen to pneumocystis jirovecii discussion separately in the infections component, where I've highlighted this aspect. Now we will be talking about what is called as atypical pneumonia. This is also called as walking pneumonia. Now, why they call it walking pneumonia is because traditionally a pneumonia patient is not supposed to, walk into your OPD and say, sir, I'm having fever, I'm having productive cough, I'm having breathlessness. I mean, the patient would be so sick, whether it be COVID-19, whether it's going to be viral pneumonia, bacterial pneumonia, that once they get out of their car, your casualty entrance is like 50 steps from where the person would get down from his car. He's not going to be able to walk those 50 steps. You will have to provide a stretcher, a wheelchair, whatever. So assistance has to be provided. You don't have pneumonia patients coming in as a walk-in. But in some cases, there will definitely be a possibility that the person would be coming walking. And when you do an X-ray of this patient, the X-ray might be white. You wondering to yourself, man, this guy, his symptoms are very limited, and his X-ray is showing extensive bilateral infiltrates, maybe something like a ARDS chest X-ray. So you called up the radiology department and you said, did you swap some X-ray? Some very sick patient's X-ray has been marked as this person's X-ray. They said, no sir, we did a double check. It's this guy's X-ray only. The radiological findings are not matching with the clinical profile of this particular patient. The organism here would be Mycoplasma. And at the moment, I'm not writing it though, because I'm going to do that subsequently. Lots of time in Mycoplasma pneumonia, you might be having atypical features like even diarrhea described in the question. Most of the time, he will describe even loose motion. So it might look like a very minor thing to you, but I'm saying a pneumonia patient is having GI symptoms. That's definitely an atypical aspect. Apart from this, another atypical pneumonia to be remembered is chlamydia. This would be chlamydia psittaci that I'm talking about, or chlamydia pneumonia as well. The point is, especially if he says contact with birds, then you need to take into consideration chlamydia psittaci as well. The third important organism is Legionella pneumophila. Now there are two aspects that I want to say for Legionella pneumophila. One, it can cause only routine upper respiratory tract infection, routine URTI-like symptoms. Those routine URTI-like symptoms is written as Pontiac fever. But Legionella pneumophila by itself would contribute to what we read as Legionnaire's disease. And why is this important is because Legionella pneumophila as an organism can spread via water droplets. Looks very surprising. I mean, normally we read about, droplets per se of the sputum of another person. Like if I'm coughing here and somebody is near me within 3 feet area, he can get infected from me. But I'm talking about this guy, he went to a hotel, he's taking a bath and the shower when he's taking. So there could be aerosol of water droplets. He's taking a shower and aerosol of water droplets might be having this organism which is going into his lungs. And more importantly, Legionella pneumophila MCQ might even talk about seizures. Why would that be so? Is because this condition would be associated with syndrome of inappropriate ADH secretion. More water in the body will cause hyponatremia. and this hyponatremia would contribute to seizure. So you can understand why I'm saying it is atypical, because I'm talking about pneumonia, right? Pneumonia patient having seizure, first thought process of yours is it could be hypoxia, but I'm telling you it is not hypoxia, it is electrolyte imbalance. So if you read a question of pneumonia in which GI symptoms are given, in which you are having hyponatremia described, seizures present, then you always have to think in terms of atypical pneumonia in a patient. I can also at this moment jot down viral pneumonias also. So obviously COVID-19 would fit the bill. Then would be influenza A. This would definitely respond to amantadine. This would be H3N1. Then we also had bird flu and swine flu, which very well would be responding to oseltamivir. So the message here is that viral pneumonias are anyway to be considered. And from the pediatric perspective, we also read about respiratory syncytial virus, which causes bronchiolitis, but subsequently can cause even pneumonia manifestations. Another allied aspect which should be remembered, especially with influenza A infection, you could be having super added bacterial infections. This is itself a question. With which viral infection super added bacterial infection would be present? The answer would be influenza A, and most of the time the bacteria which would be present here is fairly a dangerous one, Staph aureus. So it's going to cause development of another radiological finding, that is pneumatocele, and these pneumatoceles can rupture also, and if the pneumatocele will rupture, it can contribute to the worsening of the respiratory distress of the patient after admission. So if you read a question that a pneumonia patient was admitted and there is a worsening of symptoms, I repeat the fact once again. You see, you admit pneumonia patient because he's bad. He's having, SpO2 is less, respiratory rate is more. He's not able to talk to you, talks in monosyllables, or if it's a child, the child is drowsy, he's not opening his eyes. So you admit sick patients. But somebody who's already sick is becoming sicker and sickest. He's already sick and he's becoming more sick after your admission, let me say after 1 or 2 days, then you must consider this possibility that there could be pneumatocele secondary to Staph aureus pneumonia, which could have contributed to a rupture of the pneumatocele and then a development of a pneumothorax in a patient. In fact, this has been asked in the previous, we used to call it AIMS exam, now we call it INISET exam, but you definitely have to remember this statement: a known patient on pneumonia, sick patient on pneumonia on vancomycin. He himself gave a hint also, because vancomycin, when you read, Staph aureus. He said a sick patient on pneumonia already on vancomycin for 2 days is now having worsening of symptoms, and he gave an x-ray also. So a lot of guys picked up the x-ray fact also, but the concept is that why is a known case of pneumonia developing a pneumothorax? That's the pneumatocele, that's a dangerous lesion that develops after Staphylococcus aureus, which is the causative agent in that particular case. As a general rule, I can also say the fact that for the superior conditions, Mycoplasma, Chlamydia, Legionella, Pneumophila, I'll be using macrolides and doxycycline. I'll write the treatment subsequently, but you very well know macrolides would be the primary approach against Mycoplasma pneumoniae, and doxycycline will be a primary approach with respect to Chlamydia. Legionella, again, macrolides would be more than sufficient. Then another scenario that they love to ask is anaerobic pneumonia, and this would be secondary to microaspiration. So let's see how he would frame the question for you. But at the moment, the basic message is that one of the commonest organisms in the GI tract, is not E. coli, but is anaerobes. And the same organism, anaerobes, are also found in saliva as well. Especially those people who would be having gingivitis, poor oral hygiene, the concentration of anaerobes will definitely be higher. Now, if a person is having impaired airway defenses, like this person, he consumed a large amount of alcohol and drugs also, he took a cocktail of alcohol plus drugs. If a person is knocked out due to the impact of alcohol plus drugs, he would be having impaired airway defenses and he might be aspirating on his own saliva. I'm not talking about a large amount of aspiration of a few hundred ml of saliva, I would say secretions. I'm saying maybe few microliters. That's going to go down via the vocal cords into the trachea and then into the distal bronchial tree via the conducting airways, and it will contribute to development of an anaerobic lung abscess. So the message is, if he gives you a scenario of a patient whose GCS is less than 8, Because anytime if a patient is comatose, there would be impaired airway defenses. You definitely need to consider it. Whether it be a patient, a vagabond, right? They say this guy was found unconscious under the flyover by the police PCR van, and they brought this guy over to your hospital. He's burning hot. He's having a cough, productive cough. Initially, there's a lot of rattling coming from the chest because of the secretions. But subsequently, when you run an X-ray, you find that he's having a pneumonia. In fact, this pneumonia can progress even further and even cause a lung abscess, because anaerobes per se are going to be nasty, and by the time you initiate treatment, local damage would have occurred. So whether he talks about a patient who is a known epileptic and he went into status epilepticus or GCSE, and he ended up with aspiration of his own saliva, or it's going to be combination of alcohol plus drugs, you definitely have to consider anaerobic pneumonia in your discussion. And one of the bad news here is, as I said, this could result in developmental lung abscess in the patient also. Now, to trouble you in the exam, he could write the word primary lung abscess, or he could say the word secondary lung abscess. So also let's work it out. I mean, what do you mean by the word primary lung abscess? That simply means patient had anaerobic pneumonia, it worsened, and that contributed to an abscess. Is after all, in the lung, it's a cavity which is filled with pus, and there would be air fluid level. But if he changes the MCQ slightly and he says what organism is responsible for secondary lung abscess, then the answer is not anaerobes. Then I'm not talking about aspiration. Then you have to think in terms of Staphylococcus aureus, or you have to think regarding gram-negative bacteria. Or for that matter of fact, he could also talk about embolism of bacteria to the lungs. Now, where is this embolism coming from? It is coming from the heart. This person is having infective endocarditis thanks to Staph aureus, and the vegetations are getting embolized to the lungs by the right side of the heart, let me say, and therefore the person could be having development of a lung abscess subsequently. So these are three accessory facts that I want you to remember. Primary lung abscess means microaspiration of saliva, gingivitis component severely present in the patient, so and the treatment was delayed, diagnosis was not made, patient came late, whatever be the scenario, it will cause a primary lung abscess. Secondary, as the name suggests, coming from an alternative source. I mean, this guy is having, let me say, exposure to community acquired Staph aureus, right? MRSA, CA-MRSA. Or it could be standard gram-negative bacilli as well. So the terminology definitely is worth remembering. And let's now work out a question that has been asked in the exam. Now the question that came was describing a 20-year-old guy, and he said on the Holi festival, like a lot of people do crazy things. So this young chap, he's a college going student, he consumed a large amount of alcohol along with drugs, and then subsequently he came back home and he was sleeping continuously for 2 days. His mother was very worried. She was waking him up, and obviously mothers are always worried about their kids, and she was like, she says subsequently that doctor, he was partially opening his eyes, like when I'm calling out his name. Initially, I mean, he was totally zoned out, right? And he was not opening his eyes, but maybe at the end of the first day, he used to open his eyes, look at me, and again said, Mama, let me sleep, and go back to sleep again. So I thought that, okay, he'll be fine. Maybe he had too much of partying. But after 2 days, let me say, when the intoxication part reduced, that's when he woke up with the high-grade fever that was associated with chills and rigors. He was also coughing bad. This was a productive cough. There was rather bronchoria present. It was a purulent bronchoria present. So that's when you start understanding that there could be a lower respiratory tract infection that could have developed in this patient. In fact, to supplement this, he also gave a chest x-ray, and I'm just going to hand draw this before you. What actually was the image like this, and after the exam, when I discussed the question with my students, I mean, they hand drew this before me, that one of the students said, sir, I could see a very clear, distinct, circumscribed shadow with lot of whiteness in the lower part. Right, you can see the whiteness in the lower part. This is where the pus is, but then subsequently here you can definitely see some air. So what I'm talking about is air fluid level. You guys are comfortable with air fluid levels with respect to a X-ray abdomen, but a air fluid level being visualized in a X-ray chest definitely points towards the fact that this guy has developed a lung abscess. And considering the fact that this guy was intoxicated, his GCS was on the lower side, so there's a possibility that microaspiration has occurred, and I will definitely be starting this patient on treatment for anaerobic lung abscess. While I'm writing it, you guys can comment here without looking at the notes. Can you tell me what antibiotic would you give for anaerobic lung abscess? You will be answering in this particular case as clindamycin. In fact, this was the precise question. He did not ask you only the diagnosis. He said, what's the treatment for this chap? And a lot of guys casually answered metronidazole, because obviously they had read about microaspiration, saliva being responsible, anaerobes being present in the saliva. But casual answer given was metronidazole. It's not the scenario. It is rather clindamycin which is to be given. Now the next fact is to be listened even more carefully. I know you are listening to me carefully, but the few variations in the words will matter a lot now. If the question simply says a alcoholic patient was admitted with diagnosis of pneumonia in your hospital, what is the probable organism? The answer will still be pneumococcus. So you would be saying, sir, all the way you have been talking about all these aspects, now suddenly pneumococcus. See, after all, alcoholic is living in a community just like a AIDS patient is living in community. Suppose a AIDS patient is living in community and is taking cart. Even if he's taking cart, his immunity will be definitely, better than what a traditional AIDS patient without cart would be. Even he can develop pneumococcal pneumonia because he's living in the community. Similarly, alcoholic living in community, he can develop a pneumococcal pneumonia. But if you read a question where alcoholic is knocked out for days altogether, under severe intoxication, wakes up subsequently with air fluid level, then definitely a lung abscess is to be considered. Then another twist in the MCQ can be, in fact, I'll just use an alternative color to highlight this so that you can remember. The question will say the patient of routine alcohol consumption is admitted with the diagnosis of pneumonia, and the doctor has observed or the nurse has brought to the doctor's attention that the sputum being passed by the patient has this following consistency, that is a red currant jelly sputum. The moment you read this, you know that you will change your answer now to Klebsiella pneumoniae. While I'm writing this, I want to say that there is a table which is given in Harrison for organism specific approach to pneumonia per se. We all think that we know this from microbiology classes, we'll be able to crack it, but I have seen people messing up in the actual exam. So my humble request to you would be to keep the attention on and keep on listening to it, because I have seen people messing up. Let's do another aspect just for completion's sake. I said there's an alcoholic, he is admitted, he also had impaired airway defenses. It could be not only alcoholic, I mean any patient with impaired airway defenses. That could be a patient of amyotrophic lateral sclerosis, that could be a patient who's had stroke, it could be a patient with scleroderma. In scleroderma, obviously it's not the impaired airway defense, it is that the lower esophageal sphincter is relatively relaxed, so there's a possibility that some of the GI secretions can definitely move up. But the point is, ultimately, if there is entry of bacteria into the lower respiratory tract which is considered to be sterile, there are definitely bound to be problems for the patient, and we need to consider anaerobes in this particular case. You also know from microbiology that the alternative name for Klebsiella pneumoniae would be Friedlander's bacillus, and I'm just putting that name on record here, Friedlander's bacillus, so that's why he will write the word Friedlander's pneumonia. Now, if he changes this from alcoholic to, let me say, a COPD patient, in those circumstances, however, he describes a smoker developing pneumonia, right? Then the first organism is to be answered not as pneumococcus, it is to be answered as Haemophilus influenzae. And as I said, this is basically determined by extensive amount of studies where we have done sputum cultures, PCR on the sputum, that we have been able to find epidemiological data like this. Then if he says cystic fibrosis, then everybody will answer Pseudomonas. So he will deliberately not say cystic fibrosis, but will say structural lung disease. What he means is that this person could even be having bronchiectasis. In fact, bronchiectasis most of the time follows recurrent episodes of pneumonia. So any patient with structural lung disease, like I would say Kaltenegger syndrome, where the problem is in the cilia, or a patient who's having cystic fibrosis where cilia are proper but the sputum is very thick. In these circumstances, there could be a biofilm in the lung of Pseudomonas aeruginosa. This nasty organism will be contributing to then even so much of pus that even the large airways will be filled with pus. They would be damaged to the elastic component of the lungs. They would be damaged to the cartilage component, and the airways will dilate, and that's why you get cylindrical bronchiectasis. Subsequently, there's a separate video on bronchiectasis in the app as well, so you can definitely after this video scroll down for the same. In some MCQs, especially of pediatrics, I have noticed that he has stopped asking about Pseudomonas aeruginosa for cystic fibrosis because everybody is able to answer it. In a nasty competition that is present nowadays, you will notice that Pseudomonas may not be in the options, and there would be another organism coming in place that's gonna be Burkholderia cepacia. So definitely remember both of them. I have already explained that if he describes pneumonia in a patient who is having exposure to birds, then you need to answer it as psittacosis. The organism would be Chlamydia psittaci. On the other hand, let me say if he describes exposure to bats, like this particular chap, he works in Discovery Channel and he went into a cave, and I mean bats are obviously coming into picture for Nipah virus and also for the initial spread of COVID-19, but exposure to bats and then pneumonia findings, we have to definitely keep histoplasma also in the picture. In fact, the alternative term that we will read is Cave's disease or Darling's disease, as you all know from microbiology. The next patient is a hunter. So he shot a rabbit, he killed the rabbit with a bullet injury. Now he's skinning the rabbit. So while he's skinning the rabbit, the ticks that live on the body of the rabbit, now they're deprived of nutrition. So they jumped on from the body of the rabbit to the human being and bit the hunter on his hand. The hunter was bitten on the hand, not by the dead rabbit, but by the ticks that are living in the body, and they're not getting nutrition anymore. What I'm talking about here is a infection, bacterial infection that can come in initially in a person and can even cause pneumonia manifestations. That is tularemia. In fact, this has been asked in various exams. Occupational exposure to rabbits, or like I said, a hunter exposed to rabbit, then tularemia would come in. The organism which is present here is Frankicella tularensis. Then another scenario can be that the person might have gone into a hotel. You see, he has checked in into a luxury cruise. In fact, when actually COVID started, you would have heard about a ship by the name of Diamond Harbor, and this ship was actually anchored off the coast of Japan, and they did not allow those people from that luxury cruise to get down, primarily because COVID spread in the ship primarily. So what I'm saying is that if somebody is on a luxury cruise, obviously COVID-19 can anytime be there, but then another aspect with respect to luxury cruises would be Legionella pneumophila, which as said can spread via water droplets. So I mean these are again, I'm repeating, these are organism specific approaches. We think that we are remembering them or we can correct them from microbiology, but I have seen people not being able to do it, so I thought let me just highlight this. Yes guys, so I'll put this for you guys. This guy is having occupational exposure to sheep and goats and he's having a pneumonia, so we're gonna call it a query Q fever, right? That would be Q fever. We always read about Coxiella burnetii. We read about Coxiella burnetii in infective endocarditis, saying that only one culture is sufficient instead of having multiple cultures positive for other organisms. Today I'm talking about Q fever with respect to pneumonia manifestations, exposure to sheep and goat. And since I have to, jot down the data also, and I can't obviously write as fast as I can speak. So this, I said verbally a couple of times, stay in a hotel or on a luxury cruise. Then apart from COVID-19 pneumonia, which can spread very rapidly, in earlier times when COVID was not present, the organism to be remembered is Legionella pneumophila. The importance I've already highlighted. SIADH is associated, so they can be a dilutional hyponatremia and there could be development of seizures in a patient of pneumonia, and that's again atypical because traditionally pneumonia, even if seizures will occur, they would be hypoxic in nature, and the least you would ever imagine is that a pneumonia patient is having an electrolyte imbalance. Now, having described these organism specific approaches, let's talk about the standard clinical features that can be seen in any patient with lobar pneumonia. The patient would be having high grade fever. In fact, because there could be fever contributing to tachycardia, so most patients will definitely describe some kind of chest discomfort, even palpitations. The bad news is that if it is gonna be MRSA coming in, Staph aureus coming in, then the damage can be extensive, not only to the level that person can develop a pneumothorax, but you might even read about hemoptysis in a case of pneumonia. I want you to remember the fact that if a patient is having CMRSA, then hemoptysis can occur. Traditionally, in pneumococcal pneumonia, this is optional if you want to note down. In pneumococcal pneumonia, in textbooks, it is usually written patient would be having a rusty sputum, though we do not nowadays base our diagnosis on the color of the sputum, but the term rusty sputum is usually described for pneumococcal pneumonia, or like I said, a red currant jelly sputum is seen with Friedlander's pneumonia. So those are some kind of hints which are present. But with Staph aureus, you not only can be having a erosion of a pneumatocyte and it's gonna pop off, but it could also damage eroding. Once the pneumatocyte is formed, it can damage the adjacent blood vessels, and therefore hemoptysis could also be described. Then patient might complain of chest pain. This is mainly secondary to the pleuritis component. There will be a very clear-cut pleural rub that you will be able to hear, and this pleural rub would primarily be heard or mainly be heard in the phase of inspiration. In contrast, when it comes to pericardial friction rub, it can be heard irrespective of the phase of breathing primarily. The patient is also telling me now that I feel short of breath, take me to the hospital, I feel as if I will die. Because of decrease of oxygen concentration, there would be headaches in the patient. Going to the washroom would not be possible. The body will hurt tremendously. There would be myalgia. For the atypical cases, there would be nausea, vomiting, diarrhea that would be described. There can even be seizures, mainly due to electrolyte imbalance, hyponatremia, which I've described mainly for Legionella. Once you have evaluated the symptoms of the patient, then especially these, I want you to give importance to these in the exam, apart from traditional features of pneumonia, which are easy to pick up. Now let's look at what are going to be the examination findings that will be present, and bronchial breathing is important for you to pick it up. The respiratory rate will be on the higher side. Most of the time in severe COVID, respiratory rate is more than 30 and SpO2 is less than 90. I've highlighted severe COVID-19 pneumonia is RR more than 30/90 is to be remembered. Respiratory rate more than 30, SpO2 less than 90. This chap would be using accessory muscles of respiration. So since there is fast breathing, if you will do ABG at this point of time, you are gonna get a respiratory alkalosis. I repeat the fact once again. In all cases of COVID-19 pneumonia or any type of pneumonia, because the patient initially is breathing hard, you would be having a type 1 respiratory failure. There would be carbon dioxide washout. There will be respiratory alkalosis. Now, if this patient does not get a hospital bed, then the respiratory muscles will get tired. It's like happened in COVID-19 pneumonia, hospital beds, and it happened in almost all countries. Countries ran out of hospital beds, people are dying in their cars. That's going to be ultimately respiratory muscle fatigue that will cause type 2 respiratory failure. Respiratory muscle fatigue will cause carbon dioxide retention. So initial presentation of any pneumonia would be a respiratory alkalosis. If you don't give treatment and they develop muscle fatigue, that's going to contribute to development of type 2 respiratory failure and a carbon dioxide retention. The diaphragm is working overtime, so you will notice that the lower part of the chest would be sucked inside every time the patient is breathing. So especially in children, it is easier to pick up subcostal recessions. Now will be the traditional findings with respect to lobar pneumonia. You will be checking for tactile parameters because the lung has become solidified, because there is pus present, there is presence of alveolar exudate, so tactile parameters is increased, vocal resonance is increased, and when you will be doing percussion over the chest, normally the percussion over the lung is resonant, but in this case the percussion note will be found to be dull. In fact, he might say stony dull if there is a para-pneumonic effusion, because sometimes there could be combination pneumonia plus a pleural effusion also that can translate into empyema. But if you read the word stony dull, you have to think in terms of, I'm talking about a pneumonia chap with a stony dull note, you have to think in terms of a para-pneumonic effusion in a patient. The next point, you guys can tell me here, what will happen to air entry in the conducting airways in patients of pneumonia? The character of breath sound will definitely change. I mean, you and me would be having always vesicular breathing, and this patient will be having features of bronchial breathing. Can you tell me what's going to happen to air entry, guys? Your answer will be air entry will be normal because there is no occlusion of the airways. There is no compression of the airways. The pus is not in the airway. The pus is in the alveoli. So air entry is normal. Air entry is definitely absent in pneumothorax, but it is normal in patients of pneumonia. It is the character of breath sound that will change, that is bronchial breathing. Though crackles may also be heard, like in COVID-19 pneumonia, you might be able to hear some crackles, but in bacterial pneumonia, crackles are usually heard in the later part of the disease when you start giving antibiotics. If they ask you in the exam, reliable auscultatory finding of diagnosis of pneumonia, it implies lobar pneumonia is what is being talked about, and your answer would be given as bronchial breathing, in which the inspiratory and the expiratory part would be having a very characteristic audible gap. You see, when you and me, I'll talk about ratios also, but more than important than ratio, I mean, if I just say ratio 1 is to 3, 3 is to 1, it really doesn't make sense. So the important thing that I want you to understand is that if you are hearing breathing over the lung of a normal person like you and me, then there is no audible gap present. Like I would say, this that I'm drawing in red is present in bilateral lung fields of yours and mine. This is the normal breathing that is present in you and me and would be called as vesicular breathing. In vesicular breathing, the inspiratory part is relatively longer as compared to the expiratory part, and over and above this, there is no audible gap present. But in bronchial breathing, you can practice hearing to the bronchial breathing by hearing over manubrium sterni, over the central part or close to the trachea, just below the trachea. You can be having very classical finding present of bronchial breathing. That is normal in you and me, right? Infratrachea. But then if it's present over the lung fields, definitely not present. The ratio in this case will definitely be the fact that the expiratory part in this case will be taking relatively longer time. Why? Because the lungs are damaged. You see, inspiration is mainly a work which is going to be done by the diaphragm, so diaphragm can still pull through. But expiration, well, it's a passive process. The lungs are damaged, so it's going to take a relatively long time or longer time. So the ratio would be something in the range of about 1:3. Some books might say 1:2. Some books might say 1:3. But the point is, I mean, you cannot measure a ratio. No? This is 1/3. This is 1. That's a little difficult. So I would suggest you that when you're listening, try to focus on the audible gap component. Then a couple of interesting classical findings coming up here. One of them would be called as bronchophony, and sometimes you will notice that instead of writing the word bronchophony, he will write the word whispering pectoriloquy. Now the concept behind both of them is simply the fact that because the lung is solid, as a result of it, the sound will become relatively clear because sound travels relatively better in solid as compared to liquid or per se in gases. So let's look at, what is the fundamental difference? In bronchophony / whispering pectoriloquy, what I will do is, and you don't need to note it down, I will be like saying the word 99. I will tell the patient, repeat the word 99 or say 777 or 99 again and again. Now, when you say 99, like if I'm saying 99 before you, you can hear me. But if I sit with my face away from you, right, you are sitting behind my back, and I slowly say 99, 99, 99, and you auscultate over my lungs, then 9 and 9 will be, a little overlapping. It will be like sound coming from the conducting airways. You will notice that this will be not very, very, I would say, clear, especially if I whisper the sound. If I whisper, the sound intensity is very less, and you're sitting behind me, so you cannot, maybe I will ask my patient to whisper at such a low level that I obviously cannot hear him. But in a pneumonia case, when you're auscultating over with the stethoscope over the back, though the patient is whispering very softly, it will sound to you as if he's speaking in your ears. I said he's whispering so softly that a normal person will not be able to hear him, but the stethoscope of yours is conducting that sound, which is through that solidified lung, so well that you will be able to hear the word 9 and 9 coming very, very, very distinctly. So whispering pectoriloquy simply means that the sound that is being produced by the patient is of an intensely low intensity as compared to that of bronchophony. Both of the concept wise are same. Lung is solid, conduction will be relatively better. It is just that the intensity of sound that the patient will produce to while he's saying the word 99, 99 will be slightly different. I mean, the word whispering simply highlights that the patient is talking below the routine threshold of what a normal person in the same room can hear. Another very interesting finding is egophony. So let's look at egophony. It begins with alphabet E. Now, if I say the word E, you can obviously pick up the word E that I'm saying. But if a pneumonia patient, you're asking him to say the word E, it's going to be heard like A. Now, why that is happening is again because of the consolidation component. In fact, this A will definitely be having a nasal twang also. I would say a nasal component, just like Himesh or Reshamiya component. A. So I'll say it before you know. I ask the patient to say E, all right, and it's coming like A. So that A is also having a nasal component present. I mean, that's what you're hearing over the lungs of the patient. So that's egophony that comes up. So these are the findings. I mean, the inferior ones that I've highlighted are very classical ones. They will make the diagnosis of lobar pneumonia very easy for you. So therefore, in the exam, most of the time, like this time, they gave the question of AIDS positive patient having bronchial breathing, and I said it is pneumococcus, which is primarily to be considered. I would also like to state the fact that pneumonia per se as a disease, it's the host response that causes a lot of problems for the patient. And it's not that once the pneumonia part is getting resolved, everything is fine. You would have seen this in COVID and will also see this with pneumococcal pneumonia, that there could be production of toxins or cytokines that can trigger MI. Yes, guys, we lost a lot of COVID-19 patients, not because of COVID-19 pneumonia. We were able to save them, but then they suffered from MI in the hospital or after getting discharged. That's because of the cytokine storm. Similarly, with pneumococcal pneumonia, there could be release of pneumolysin. This pneumolysin can trigger platelet aggregation or platelet. Once the platelets tend to, come close together, the clot formation will start occurring. So I want you to also remember that even if a patient of pneumonia is in a recovery mode, like 2 or 3 days after admission, the worst is not over, because he might end up with development of myocardial infarction. This has to be remembered both in COVID-19, though in COVID-19, because we lots of time using heparin, no, so the chances are still reduced. But in traditional pneumonia, bacterial pneumonia, we don't use any heparin for the patient, so the chances can definitely be substantially high. And I want to highlight the fact that crackles or crepitations are a feature that you classically see with the either a pneumonia which has been treated with antibiotics in the later phase, or if I say fine crepitations, they are relatively more common in congestive heart failure. So crackles can be heard in pneumonia, no doubt about it. In pediatric age group, you definitely have crackles, but if they put crackles in the question and bronchial breathing also and ask you to select one, then I've sensitized you to the fact that the answer would be given as bronchial breathing. Let us now focus on the workup of this patient. The first test that you would be doing in this patient would be a complete blood count that will be showing an elevated TLC. Then in COVID-19, we definitely have is a leukopenia, and the neutrophil lymphocyte ratio plays an important role in determining the prognosis. I've highlighted that if the neutrophil lymphocyte ratio goes more than 6, goes up to something like 19, I've seen even going up to 20, 25, the message is higher is the NLR ratio, more are the chances of deterioration in COVID-19. When it comes to chest X-ray, there could be various patterns that could be present. I have already highlighted them in the starting of this discussion. It could be round pneumonia, a circumscribed shadow with a history of few days, could be a pediatric case. Especially in children, you might be noticing diffuse infiltrates in both the lung fields, so it could be bronchopneumonia. The traditional information is obviously for lobar pneumonia, and then there could be combination of findings of pneumonia plus pleural effusion given in a question, because lots of time patients might be having a parapneumonic effusion. In fact, if he says what is the number one cause of a parapneumonic effusion, it is, after all, I mean, the name is given there, pneumonia, and this is gonna be an exudate, so it will satisfy the Lights criteria now. And if you don't treat this, then a parapneumonic effusion, like there's a delay in instituting the correct antibiotic, this will deteriorate into a empyema. Blood culture and sputum culture both are important, though the yields are on the lower side because lots of time patients might have taken over the counter available antibiotics, but still as a protocol, both sputum culture as well as blood culture should be done. In some cases, however, getting the sputum of the patient may not be possible, so we subsequently can go in for a bronchoalveolar lavage in the patient if possible or feasible. They have asked in the exam that how would you determine that the sputum sample that has been taken is adequate, and is it actually sputum or is it saliva? So he says that on a microscope examination, if there are more than 25 neutrophils and approximately roundabout or lesser than 10 squamous epithelial cells present, it means the fact that one, you have taken the sputum of the patient, and this data that I mentioned is primarily for the adequacy of the sample. Because you see, if the sample amount is lesser or if it's mixed with saliva, the sensitivity of the report will dramatically reduce. And if you don't know which organism are you fighting against, then you are randomly shooting in the dark. I mean, after all, you need to know your enemy to fight him. If you are not aware of who is your enemy and you are just randomly firing, you may not end up hitting him or might be using inappropriate antibiotics. So first, what we should do is we should be sure that, okay, we have taken the sputum of the patient, right? And to determine the adequacy of the sputum, the criteria is what I've highlighted, 25 and 10. That's the information to be remembered. And then obviously sputum culture of the patient will be processed. Now, because both of these would be having a low yield, therefore, we had to go in for alternative strategies also, to the level that we are even doing urine evaluation. We are talking about urine antigen tests. Urine antigen tests are available for pneumococcus and is also available for Legionella pneumophila. So this is itself a question that what test can be done for identification of Legionella pneumophila. It's not a sputum culture, rather you will answer a urine antigen based test, because this organism would be shed in the urine of the patient subsequently. Over and above this, we can definitely do a PCR if available. I mean, again, the facilities would be relatively lesser, and if PCR is done on bronchoalveolar lavage as compared to sputum, nothing better than that, right? I mean, the deeper you go in the lungs, the deeper part of lung secretions that you're able to get, you would be having a higher diagnostic yield. Apart from this, biomarkers will also be tested. Biomarkers I'm talking about at the moment are related to sepsis, because ultimately pneumonia can contribute to sepsis and development of septic shock. So CRP plays an important role. CRP is anyway grossly deranged in COVID-19 pneumonia, and another parameter that is going to help you in determining the possibility of development of sepsis would be procalcitonin. So these are battery of tests which would be done apart from obviously a chest x-ray. Chest x-ray is anyway gonna be done because you need to identify what is the pattern, what are the lobes that are involved in COVID-19. If I want to be rather more aggressive in my approach to determine the severity of the disease, though that may not actually change the course of the disease per se. I have seen people with CT score of 25 out of 25 and then recovering, and people who are having scores of 10 on 25 and then suddenly deteriorating. So I mean, we cannot predict on basis of a single CT report in COVID-19 whether a person will recover or whether he will deteriorate. And even in this particular case, I mean, if we are having access to CT facilities, it would obviously be advantageous, and that would help you pick up a parapneumonic effusion even much more earlier. The question now arises, should you admit the patient or should you be treating the patient on OPD basis? So what we have here is a curb 65 score that will be helping you identify who are the patients who need a hospitalization, because I want judicious resource utilization. Like in COVID-19, what happened was anybody who had COVID-19 in March, April 2021, even if they had mild COVID, they were getting admitted and they were receiving remdesivir to prevent a deterioration into severe COVID. That actually was not the case. I mean, remdesivir was not working. So the point is, I mean, should you admit everybody or should you admit selective cases? Everybody on their own, patients were deciding, I'm having COVID, I need to get admitted. But when it comes to lobar pneumonia, that's not the case. No, you are the one who will decide on the basis of the following parameters. That would be confusion, then would be values of urea, which mathematically you have to remember would be more than 7 millimoles per liter. Then respiratory rate, obviously this is more than 30. For blood pressure, it has to be lesser because after all, person is going into septic shock subsequently. So BP less than 90/60. And then you will obviously consider age of the patient more than 65 years, and this will help you determine should you admit a patient or not. Now how? Let us assume a case where none of these parameters are setting in. Like you are having a patient who's 60 years of age, his BP is 120 by 80, or let me say even on the higher side, he's hypertensive, respiratory rate is, let me say, 20, and he's talking to you. He says, doctor, I don't want to get admitted. Hospital is a horrible place to me, but I'm having this breathing difficulty, and my x-ray is showing a patch, maybe lobar pneumonia. So if the score of the patient is 0, that does not mean that he cannot die. It simply means the fact that this particular patient, ideally the treatment should be done on a OPD basis, though the mortality rate with a score of 0 has been determined to be approximately 1.5%. If the score of the patient is between 1 to 2, now here is the catch, 1 to 2. Suppose it is 1, and when I say 1, it means only age is more than 65. Suppose only age is more than 65, then he says you can decide on case to case basis, assuming that he's, let me say, retired from the army, he does not have any comorbidities, no diabetes, no hypertension, no coronary artery disease in the patient, is very fit, he retired from the armed forces, and he says, I don't want to stay in the hospital, doctor, even if the score is 1, only age is more than 65, right? He's 70 years of age, he does a morning jogging every day, 5 kilometers, 6 kilometers, so very fit chap, and the score is 1, considering the age, he says you can still go for OPD basis treatment. But if two parameters are present, then you definitely should be admitting the patient, because the mortality rate goes up. I want to highlight here by putting two lines under one to say that if only age is more than 65, he mentions in Harrison, then the doctor can decide on case to case basis. If it's an old man, 70 years of age, he is having comorbidity, diabetes mellitus, hypertension, underwent a coronary artery bypass grafting, I would not like to take a risk and say, and tell this guy, sir, please get admitted. But if it's a fit chap, like I gave you a scenario, then if only age is positive and he's a fit chap, no comorbidities, we can definitely try a OPD basis treatment. In the exam, the NEET 2021, it was actually two factors that were positive: age more than 65 and the urea values of the patient were deranged. Though he deliberately in the question, I mean, gave respiratory rate and BP to be obviously not normal, higher than normal, but not at these cutoffs. Respiratory rate was something in the range of 18 to 20, blood pressure was more than 100. So it is rather, you need to consider the fact that even the laboratory parameters in the MCQ need to be checked. Not only will you consider age, because that's written right in the first line of the MCQ, 70-year-old man admitted to the hospital, but they also gave lab reports of that chap, and that's where the urea component had to be picked up. So if two things positive, definitely I would like to admit this patient in a routine general ward, and I would like to treat this case. However, if the score jumps up to 3, suppose 70 years age, respiratory rate is more than 30, blood urine nitrogen is getting elevated, or he is having a disorientation, in those circumstances, I definitely have high chances of mortality going up to 22%. This particular patient should definitely be admitted into intensive care unit, but that does not mean that the antibiotics will change. Antibiotics will remain the same only. It is that in ICU, you will be doing more intensive monitoring. So deterioration can be picked up relatively better, but the antibiotics that are used would remain the same. This slide per se is highly important. In fact, in the pneumonia topic, I would rate this as the most important slide that I want you guys to remember. Curve 65 score is used to decide the need for hospitalization. It is not the patient who will decide, like it happened in COVID-19 outbreak. It is us who will decide the need for hospitalization. We definitely have criteria in COVID lecture. I've discussed them. When would you admit, right, to a dedicated COVID hospital, when to a dedicated COVID health center. Similarly, here curve 65 score for lobar pneumonia is to be remembered. We shall now be talking about treatment of a patient of pneumonia. So I'll be first describing, assuming that my patient is having a curve score of 0. And there can be two possibilities. One can be, and the one on the right that I'm writing at the moment is more probable to be asked. He will describe, he will not say the word comorbidity. He will say 60-year-old chap or 70-year-old patient, known case of hypertension, diabetes, underwent a CABG last year, is admitted to your hospital right now. So comorbidity could be described in the question. Or he might say that the same chap, he is not having comorbidities, but he was admitted with a diagnosis of pneumonia in your hospital only, under your care. Antibiotics, AB here does not mean antibiotic. I'm using a shortcut here to say antibiotics have been taken or prescribed to this patient in the previous 3 months. Now, the antibiotics that are going to be used here are going to be slightly different from a patient who is never having any hospitalization. Like this chap is previously totally healthy. He tells me, sir, for last 10 years I've never been admitted in a hospital for any medical or surgical reasons. He has not taken any antibiotics also. In those circumstances, the first line antibiotic to be given on the left hand side, previously healthy patient, would be macrolide. You could be using either azithromycin or you could be using clarithromycin, really does not matter. If macrolide is not given in the options, then you can definitely answer doxycycline in the same question. In contrast, for the right hand side of the discussion, comorbidity is already present in the patient. The first line antibiotic that would be used in this case would be a respiratory fluoroquinolone. Most of the time, we prescribe moxifloxacin, or we might be using even levofloxacin in the patient. On the other hand, suppose respiratory fluoroquinolones are not given, then it would be beta-lactam plus macrolide. I want to highlight that on the right hand side, it would be a combination if we are not talking about respiratory fluoroquinolone or beta-lactam plus macrolides. Overall, you can see from this discussion that macrolides are prescribed to anybody who's having a diagnosis of pneumonia because of the fact that macrolides will be covering typical organisms also and atypical organisms also. Now let us take up another scenario. So I am describing treatment once again, but my same patient is having a curb score of 2. So I have decided to admit this patient, and now let's look at what is the treatment that you will be giving to this patient on IPD basis. One possibility is that he has been admitted into intensive care unit. The second possibility is that you have admitted him into your routine general ward but not into intensive care unit. The difference would be with respect to monitoring only. If he says what's the treatment to be given to these patients, then in both of them, do remember this fact, whether he says ICU, whether he says non-ICU, the difference is only in monitoring. The treatment would remain the same. It's IV antibiotics, so beta-lactams along with macrolides would be administered in this case. Combination of the two is the one that is recommended. I did speak about beta-lactam macrolide combination, but that could be even orally prescribed with respect to OPD basis, or patient, if he wants, if he can come and you think that he's an old man and you don't want to take a risk, but at the same time the patient does not want to stay in the hospital, you can say we'll put up a cannula and your son can drive you to our hospital and we can give you IV antibiotics as well. So depending on the local availability and the local status, you definitely can modify a bit considering a high risk with respect to old population. In case in the MCQ combination is not given, then respiratory fluoroquinolones can definitely be administered here. Special mention for Pseudomonas aeruginosa. You see, especially with structural lung disease, Pseudomonas would come up, or there could be a situation for methicillin resistant Staph aureus that would be coming up. So with respect to Pseudomonas, the antibiotic approach that we can use is meropenem, or we can be using piperacillin tazobactam. In fact, most of the time you would have seen both of them rather being used in your hospital department. The only thing is either of the two plus levofloxacin, or it could be moxifloxacin. Because I've already written moxiflox a couple of times, so I have just mentioned levofloxacin here. But the message is for Pseudomonas, special cover has to be given, considering the fact that it is picked up either on a sputum culture or circumstantial evidence of structural lung disease. If it is going to be MRSA, then he mentions that you should be adding linezolid, or you could be adding vancomycin. That depends on the report that is given by the department of microbiology primarily per se, but the blanket treatment for any patient having a curb score of 2 would be beta-lactam plus macrolides plus, or if not available, then respiratory fluoroquinolones, and the approaches for Pseudomonas and Staph aureus are also to be remembered. Last but not the least, he can definitely ask you regarding the antibiotics that you would be using in ventilator-assisted pneumonia, or he might say hospital-associated pneumonia. Earlier, they had introduced a term in the older edition of Harrison, 19th edition, the term healthcare associated pneumonia. Like somebody is getting dialysis done, he's coming for a short duration and he gets infection from hospital environment. Somebody is coming for blood cancer treatment, right? This patient is admitted maybe in the morning, discharged in the evening by giving chemotherapy, and you're calling him again for repeated chemotherapy sessions, but he's not spending the entire duration in the hospital. He comes and goes. So those patients who are taking intermittent hospital care could be suffering from infections acquired from the hospital environment. So they used to call the term healthcare associated pneumonia. The difference was hospital acquired pneumonia, patient is permanently admitted. Healthcare associated pneumonia, the patient will be taking some intervention from hospital, go back home, again come back the next day. But all these definitions are artificial. So in the current edition, he has said that do not treat the patient on the basis of a definition, but individualize the case depending on the risk factors present. Like an influenza patient, influenza A pneumonia, old man who has never taken influenza A vaccine, right? That guy chap could be deteriorate due to staph aureus pneumonia. COVID-19 pneumonia patients can end up with development of sepsis, so or end up with development of ventilator associated pneumonia as well. So you need to individualize or strategize the treatment. What I mean by individualize and strategize the treatment is that it could be a MDR or it could be a non-MDR. When I say MDR, I hope you remember that it is Pseudomonas, but if he says the word non-MDR, then it is not Pseudomonas, then it is Pneumococcus. Now, what is the treatment that is given in these patients? Then the common antibiotic which is used on both left and the right side is piperacillin and tazobactam. Yes, guys, on the left hand side it is easy to relate. On the right hand side, I want you to remember for ventilator associated pneumonia, he says give piperacillin tazobactam in both the scenarios. So what is the difference? The difference is that in MDR, because I am saying multi-drug resistant, so it could be resistant to the antibiotics that I have written. So he says you can add coverage for gram-negative organisms by antibiotics like amikacin, gentamicin or tobramycin. So that's the only difference. There's an entire table given, but I just simplified the data by saying that the common thing is piperacillin tazobactam. The only thing is considering MDR. You need to give additional cover in this case. Now, coming to the end of the discussion, I want to mention some risk factors for early deterioration in a patient with community acquired pneumonia. I'll be dividing the discussion into two. One can be clinical findings. The second one would be laboratory findings. Like if a person is having multilobar infiltrates, the chances of him deteriorating would be relatively faster. Similarly, the host immune response could cause alveolar edema so severe that the SpO2 drops relatively early. If you find that the patient is having respiratory acidosis, I told you in most cases of pneumonia there will be hyperventilation causing respiratory alkalosis, but if you demonstrate respiratory acidosis, it means there is a respiratory muscle fatigue coming in. There is an altered mentation because of the hypoxia component. The respiratory rate of the patient uniformly is more than 30 even after you have started treatment in the patient. Then these are all findings which are telling you that the chances of this patient recovering would be on the lower side. Similarly, I'm not mentioning at this point of time biomarkers of sepsis, right? Because that's a separate category. At the moment, all I'm saying is pneumonia patient who's likely to deteriorate into sepsis and then development of septic shock. So if a patient is having hypoalbuminemia, if the neutrophil count, you will notice that in COVID-19, I was mainly talking about neutrophil lymphocyte ratio, but here I'm saying if it's a bacterial pneumonia, neutrophil count is relatively lesser. There is a concomitant thrombocytopenia present, again, secondary to the infection. If there's a hyponatremia, which we discussed in patients who are having Legionella pneumophila, if there's a hypoglycemia, not hypoglycemia, these are a couple of risk factors for predicting early deterioration of patients of COVID-19 pneumonia. This is just a table which I've highlighted so they can incorporate either the lab findings or they can incorporate the other findings that I've highlighted, especially with respect to the pH of the blood, because the initial presentation is respiratory alkalosis. As far as definition of nosocomial is concerned, you very well know after 48 hours of admission, though there's an alternative definition also present, which is after 3 days of discharge. So one is the guy is admitted. He is admitted for, let me say, elective cholecystectomy, right? But after 48 hours, he ends up with pneumonia. That's one possibility. Another is he stayed in the hospital for 3 to 4 days for maybe prostatic surgery, and then subsequent to discharge, he ends up with development of pneumonia. So if somebody is having pneumonia even after 3 days of discharge, for a routine surgical procedure, and he picked up the infection from the hospital environment, then nosocomial word definitely comes into picture. So these are the aspects that I would like you to remember, and especially curve 65 score and its application would be the one that I would recommend you to remember. And at this juncture, I would also suggest to you that since you are doing these videos, I would suggest you to actually do MCQs of each topic at the same time. Because when you do MCQs, you will realize that you will pick up those minor points which can be added to the theory lectures, so that you can consolidate your notes. And this was in fact a query from one of my students today, that should I read only the notes or should I attempt questions also? They are after all given in the app, they are meant to be done, but they are to be done together. You read Pneumonia, you do MCQ, so that whatever extra you find in MCQ, you put that, jot that down in the notes, so your notes become more potent, and therefore that's the main weapon that you will be having, let me say 2 months before the exam. Because since you know, the point is ultimately there is so much of data to be remembered, our brain has a limited capacity, so we need to make highly efficient notes or books which could be revised in the next sitting. So these are the suggestions from my side. Thank you for your patience and hearing me out. Keep hammering, keep the focus on, and you will do great.